Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone. Welcome to this episode of Thinking Thoracic, an STS podcast. My name is Jane Yanagawa, and I'm a thoracic surgeon. I will be the host for this episode. Today, we have the absolute honor of speaking with Dr. Olujimi Ajijola. He is a cardiologist and really an expert in the field of electrophysiology. And today we will be discussing the topic of cardiac sympathetic denervation. I think it's such a great topic to be discussing in a podcast, especially with someone who is also not a surgeon, because it's such a multidisciplinary topic. To give a little bit more background about Dr. Ajijola, he got his medical degree from Duke University. Then did his internal medicine residency at Massachusetts General Hospital. He then came to UCLA, where he not only finished a general cardiology fellowship, but got a PhD, and then did his subspecialization in cardiac electrophysiology here as well. He is currently an associate professor of medicine in cardiology, but he is also the director for the Neurocardiology Research Program of Excellence. He is also associate director for the UCLA Cardiac Arrhythmias Center and EP programs. He is highly involved in education. He is the associate director for the UCLA Specialty Training and Research Program, as well as co-director of the UCLA Caltech Medical Science Training Program. And, he's PI for multiple multi-million dollar R01s and PO1s. And, just looking at your CV, I don't even know how to sum it up. I mean, for the audience, you can just imagine the most mind-blowing, amazing CV you've ever seen. Just a full disclosure, we are good friends for many years, and we've been talking about patients and CSVs for a very long time. Olu is a very busy clinician. Also, I run into you all the time in the OR doing those crazy long ablations that you guys do. But thank you so much for joining us today.
Dr. Yanagawa, thank you so much for that very kind invitation. And I really appreciate you raising that we're good friends. I think that just as important is sort of the friendships that you develop in the process of the work that we do. And I really appreciate you having me on here.
Awesome. Well, let's get started with some of the very basics. If you could summarize, what are the indications for surgical cardiosympathetic denervation? We can abbreviate it as CSD for the rest of the talk.
Yes, so I want to maybe start by making a distinction between the same type of thoracic sympathectomy for things like hyperhidrosis and other sorts of indications. We're focused particularly on those patients with severe ventricular arrhythmias, for whom none of the conventional therapies we have, including pharmacologic and invasive procedures, are effective. For those patients, they typically have a form of cardiomyopathy, and in some cases, actually, no clear mechanism of cardiac dysfunction. Those patients essentially have dangerous ventricular arrhythmias or ventricular fibrillation, monomorphic ventricular tachycardia that are recalcitrant to all the therapies that we have. When we get to that stage in these patients, we often would refer them for cardiac sympathetic denervation. And I'll get into the reasons why we do that in just a bit. So to maybe answer your question directly, the indication for cardiac sympathetic denervation as it stands today, and as it stands in our society guidelines from the American Heart Association, Heart Rhythm Society, and American College of Cardiology, are patients for whom their ventricular arrhythmias are recalcitrant to all of our current therapies.
That's great. I think one thing that we should really talk about is the procedure itself. It people say, oh, I'm doing a sympathectomy, but that could refer to multiple different things. And even in the context of CSD to treat this one diagnosis, you can find publications describing totally different procedures, and that does make it really hard to study the procedure and what the true outcomes are. Um, so here at UCLA, just so we're all on the same page with the audience, the procedure that we perform for these patients is to dissect out the stellate ganglion and resect the lower 1/3 to 1/2 of the stellate ganglion en bloc with the sympathetic chain down to include the T4 ganglia. And we do that in addition to transecting the nerve of Kuntz, which in general we do by transecting the pleura on the superior border of the second rib for about 5 centimeters. And we generally do it as a bilateral procedure. Can you talk about sort of the history or how we evolved to this specific procedure, and what are some of the controversies about the different surgical approaches?
Well, it's a very important and long question, so I will try to be succinct in my answer. So to start with, we know that the neurons, the sympathetic neurons that innervate the heart, and in particular the ventricles, what we call the postganglionic sympathetic neurons reside within the sympathetic chain. So they reside within the stellate ganglion and the second through fourth thoracic ganglia, en route to the heart. So about 100 years ago, a Romanian surgeon named Tomas Ionescu actually reasoned that in a patient with ischemia and ventricular arrhythmias, that if he interrupted the sympathetic tone to the heart, he might actually alleviate this patient's recalcitrant arrhythmias. And that surgery was very successful. It happened in 1918. He did just what you described, the stellate ganglion down to the fourth thoracic ganglia bilaterally in this young patient. He did that in 1918, published it in 1921, and that's really where cardiac sympathetic denervation was born. The reason that interrupting these fibers is important for ventricular arrhythmias is that we've learned over the past few decades that whenever there's a form of cardiac injury, like a chronic heart attack or heart failure or infiltrative heart disease, there is remodeling of the entire nervous system that controls the heart, and that includes the sympathetic ganglia or the neurons that reside in these sympathetic ganglia. So we can treat the heart all we want, but without addressing the alterations that happen within these neurons, we're not really, able to make as big of an impact on the heart and on the ventricular arrhythmias. So the strategy is that we are looking to remove these remodeled neurons, so that they don't essentially trigger dangerous arrhythmias by their innervation of the heart. We do this so to get to the various aspects of what you mentioned. So bilateral sympathectomy is important for structural heart disease because both sides remodel in response to cardiac injury. So if you have a patient with a heart attack, you have a patient with arrhythmogenic cardiomyopathy or non-ischemic cardiomyopathy, both stellate ganglia remodel. And we have data that shows that if you perform only a left cardiac sympathetic denervation, as has been traditionally done, there are higher rates of recurrence compared to if you perform bilateral cardiac sympathetic denervation in patients with structural heart disease. So that's why we do bilateral sympathectomy for patients with structural heart disease. Now, there are patients with genetic arrhythmia syndromes like long QT syndrome. In those patients, the mechanism of their sort of the arrhythmia protection from a sympathectomy is not due to remodeling of the neurons. Rather, it's because of inherent sympathetic drive via the left stellate ganglion. So for those patients with long QT syndrome, or even patients with catecholaminergic polymorphic ventricular tachycardia, these are inherited arrhythmia syndromes. Those patients require just a left sympathectomy initially, and if they have recurrences, they can then go into a bilateral sympathectomy. And then, one sort of final aspect of what you talked about is the importance of the nerve of Kuntz. The nerve of Kuntz, essentially, you could think of it as an avenue for fibers to bypass sort of their I guess their thoracic level. So, for example, what you might find traversing the nerve of Kuntz are fibers that say come from the intermediate lateral column of the spinal cord and route to the heart. But then once they synapse, the postganglionic fibers then traverse the nerve of Kuntz to go from, say, a T3 level to a T1 level, or vice versa. It essentially causes such that the fibers bypass their the rami you might expect them to be at, maybe for lack of a better term. So if you were to transect the nerve of Kuntz, it essentially ensures that you're not leaving any fibers en route to the heart behind. So again, that was a long-winded answer to a long question, but I hope I covered a lot of the things that you asked.
Yeah, I think that's like a great history. And, I think that we take a lot of those things in consideration. And I wanted to throw it out there. That's why, we aim to do bilateral for, these patients, but knowing that potentially you're not going to make it through both sides, we have also decided to always start on the left side in case the patient is not able to tolerate both sides. And I think that, there have been times where we considered staging the procedure as to if they were not able to do both sides, but most critical probably to start with the left side.
Yeah, you're correct. I mean, I think you're raising a very important point that I actually didn't address, so thanks for bringing it up. And that is that these patients are typically quite ill. Some are quite stable, but some of them can be quite ill. So taking them through this invasive procedure, even though it's done minimally invasively, can be quite a challenge. So in those situations, we start with the left because the belief is that the left sympathetic chain probably sort of it has more responsibility for the ventricles and the heart and the portion of the heart that's diseased than the right. Although both are important, the left is probably a bit more important.
Talking about the fact that there are risks with the procedure, or just putting these kinds of patients through, the general anesthesia and things like that, and the recovery afterwards, I think, it's clearly not like a first line choice therapy. But one of the hardest things I think for counseling the patients when we see them in clinic in preparation for the surgery is talking about how, well, we expect the majority of people to have a benefit, but there's sort of like a spectrum of benefit. And then there's always a subset of people who don't actually benefit from the procedure. And it would be really incredible if one day there was some way to, predict who was going to be in that subset that would not benefit versus those who have the amazing benefit from the operation. What do you see for like the future? Will there be ways to predict, more specifically who benefits from the surgery, and what are other important things that you think that we really need to address this, in the upcoming near future?
Yeah, no, another great question, Jane. So in terms of what the future holds, I completely agree that being able to predict who would benefit from the surgery is really of paramount importance. The avenues that we have to do that are really to identify patients where we feel that their ventricular arrhythmias are triggered by the remodeling that's happening within the sympathetic nervous system. So what we're looking for then are biomarkers of neural remodeling or biomarkers of sympathoexcitation, such that when you perform the sympathectomy and resect the sympathetic chain, you're able to remove this focus of essentially pathophysiology that's driving the arrhythmias. And to sort of go back to your earlier question about sort of the outcomes, I should mention that one of the reasons our program at UCLA has been so successful is because of the excellent outcomes that you and your colleagues have, really given us and these patients. I'd like to sort of just reiterate again that, other than the sympathectomy, these patients really have no other options other than, say, a heart transplant. That's a really invasive thing to do. So I'd like to take this opportunity to also thank you for taking wonderful care of our patients, and also thank you for your excellent surgical expertise. I mean, I think we wouldn't be here if not for that. Other things that I think we could look forward to in the future are thinking about ways to make the surgery less invasive. So the more we can minimize the invasiveness of the procedure, I think the better the patients will do, and kind of the more patients will be willing to undergo the procedure. I think other things that are important would include managing some of the adverse effects that some of the patients see. Those things include alterations in sweating patterns. Some patients get pain around the incision site, and sort of this type of pain or sort of around the ribs. And if we had ways of minimizing these outcomes, I think that would also improve how patients do. One other thing I want to mention is that at this time, we're mostly reserving this procedure for late stages. I think that there's an opportunity to really improve the outcomes and selectivity in patients, but actually moving it more upstream. Maybe we shouldn't wait until the patient's heart ejection fraction has dropped dramatically, or they've received their 100th ICD shock before we offer sympathectomy. I think that's also an important sort of opportunity in the future, is to actually get patients before they really decline in terms of the ventricular arrhythmias.
Thank you so much for those kind words. That means a lot to me. But yes, in terms of making it less invasive and some of the peri-op stuff, that makes so much sense, because we've noticed, right, how critical that post-op pain control is, because that in itself can trigger the arrhythmias in the post-operative recovery time. So a lot of those trying to be as minimally invasive is really important, but still, even with the small incisions, like you mentioned, with the robot and VATS approaches, patients still have pain, and it's so critical to have them have the most comfortable recovery possible. And you mentioned, trying to move it into a group of patients who are probably healthier, and I think that we have been doing that, going from patients who are stuck on dribs in the hospital, who are the sickest, to a lot of outpatient electively scheduled procedures now for patients who are just coming from home. That's going to be a really important part of making it the safest procedure possible. And, I think, as you mentioned, some of those sick patients too, that recently, for when we do offer the surgery for patients who have significant heart failure or low ejection fractions, that we've also been involving the advanced heart failure team for their expertise, for not just long-term goals, but also backup plans, in case things go wrong for the operation. Well, I mean, it's been incredible working with you specifically, and all the other members of the electrophysiologists in your group. But yes, it's also introduced us to a lot of the other cardiologists in general, and the thoracic and cardiac anesthesiologists who have been involved have been really critical in shaping it into a safe operation. In addition to the pain team, who have been really creative in terms of how to make sure patients, especially even patients who are on blood thinners, are going to have the safest, most pain-free recovery possible. It's been such a great experience doing this multidisciplinary thing for an operation that, for someone who hasn't done it before, can be very intimidating, not only because the patients are sick, but in our training, mostly we're exposed to sympathectomies in the context of things like hyperhidrosis, where you're told absolutely never touch anything above the second rib, and when I first started, I was imagining every single patient would have like major complications. And luckily that is not the case. We had that recent review of our cases here, and it's not nothing, but the risk of hyperhidrosis is probably compensatory hyperhidrosis is probably in the range of like 30 or 40% of the patients. But I really can only remember one patient in the last 10 years who, had it so significantly that it impaired his quality of life. And but none of the other people have even mentioned it unless you specifically ask about it. And then the Horner syndrome, maybe some droopy eyelids, maybe up to 10% of the time. But again, I can't remember a time where anyone felt that that was had any major impact on their quality of life. So going through this experience, being able to trust all your colleagues about the procedure has been just really huge for me too. And of course, all of our patients. Um,
Right. No, that's a fair point. I was just going to add that in terms of the complications, the two that you mentioned, the compensatory hyperhidrosis, as well as the Horners, what we've seen is that those have been temporary, and which is why, as you see follow patients over time, we don't get those complaints anymore. And as long as, as you mentioned earlier, you stay away from the upper aspect of the stellate ganglion, so you're resecting the lower half or lower third down to the port sympathetic chain, we just haven't seen a permanent Horners or a permanent compensatory hyperhidrosis. So the patients, again, have really done well under your expert care, and that's another reason why we're so grateful to you and your colleagues.
One of all of your publications, one of my favorite is the one where you looked at the size and shape differences. Because for a surgeon, and we don't dissect in that area very often, sometimes if you haven't seen that many, you might wonder, like, is this the stellate ganglion or not? Because there are times where it looks bilobed, and then it's maybe a little bit hard to gauge, what is the lower third or lower half based on the shape. Can you talk a little bit about that study and the different shapes and differences potentially between the right side and the left side in terms of the stellate ganglion?
Yeah, so we and thank you for being a co-author on that study with me, to really to sort of briefly uh, sort of summarize what we did was we performed a cadaveric study where we isolated stellate ganglia from, I want to say maybe somewhere in the mid-teens range of cadavers. And we profiled the shapes of the left and right stellate ganglia, identifying sort of three major subtypes that slightly differ between the right and the left. And we found some ganglia were bilobed, where you could almost make out because the stellate ganglion is the fusion of the 8th cervical and the 1st thoracic ganglion. And so you could, in some patients where it's bilobed, you could actually make out C8 from T1. We also found a more elongated form where you couldn't really tell which was C8, which was T1. The ganglion just sort of looked like an elongated sort of structure. And then the other was this sort of fusiform where, rather than an elongated or bilobe structure, it was just sort of one um, sort of a fused ganglion at the C8T1 level. And I think it's an important study because when you're in patients and you're, looking to identify, what is the stellate ganglion and where is its midpoint so you can resect below it, it can be very tricky. But we felt that if you can define what type of ganglion you're looking at based on the findings from our study, then you could sort of conceptualize what where the midpoint would be and below which you should resect. So thanks for highlighting that study, Jane.
Well, thank you so much for joining us today. Anything else that you think we haven't touched on that would be important for a surgeon?
Yeah, I think there's one last thing that I meant to raise that I hadn't, and that's the idea of what we're calling a sympathectomy. You have very nicely define what we do at UCLA, which is a complete resection and removal of the lower half, a third of the stellate ganglion down to the fourth sympathetic, to the fourth thoracic ganglion. There are some forms of the surgery where the surgeon staples the rami or transects the ganglia but leaves it in the body. These other forms of sympathectomy are suboptimal because we really need to remove the focus of the abnormal remodeling that happens in the setting of cardiac pathology, because the nervous system is very plastic. So if you don't remove the cell bodies, they find a way to sort of grow back and grow heterogeneously, and can sometimes actually be worse than the initial situation that you started with. So from our translational studies in animal models of cardiac disease, where we've studied sympathetic function, the recommendation is to remove the ganglia and not do some other form of surgery and leave them in place.
That's critical. Thank you so much for bringing that up. Well, thank you so much for joining us today. That was so fun to talk to you formally about this, and I really hope that we get a lot of listeners, because I feel like this is something that's probably going to come up more often in our field in the future. And there's a lot that we can do to help people here. So thank you for joining us, and see you soon in the OR probably.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.